Okay, so we will go ahead and get started. Thank you so much, everyone, for joining us for our first live session from our course from the Johns Hopkins Maternal and Child Health Center, India, the COVID-19 response in India, impact on women and children's health and well-being. This course was, of course, the product of our collaborations with our wonderful partners who we would like to acknowledge here, the NHSRC, the Bloomberg School of Public Health, and the ICMR National Institute of Cholera and Enteric Diseases. Before we get started with the main portion of the course, we just wanted to start off with some very quick course updates. Enrollment does remain open on an ongoing basis. So if you are joining us and are not currently enrolled in the course, you are welcome to join and continue working through the course materials at your own pace. Certificates of completion, we've been starting to receive some queries about certificates of completion. Those will start to be sent to eligible learners this coming Monday, May 9th. They are not automatically generated, so you will receive them individually for those who have passed the eligibility requirements, which means completing all module quizzes with an average score of 70%. And we just wanted to remind you all that this is the first live series in a session of guest expert topics that we will be hosting. So we invite you to stay tuned on the upcoming live sessions, the next of which is scheduled Wednesday, May 18th at 6 p.m. India Standard Time. And of course, this course would not be possible without your esteemed faculty, whose presence we have here, and one of whom I would like to introduce right now, Dr. Anita Sheth. She's a senior scientist in the Johns Hopkins University School of Public Health. She's the director of child health at the International Vaccine Access Center within the Department of International Health. And she is the director of the Johns Hopkins Maternal and Child Health Center, India. So without further ado, I would like to present Anita Sheth. And Anita, over to you.
Thank you so much, Emily. And I just also want to acknowledge all the faculty who've contributed to this course. In the previous slide, you can see Dr. Svea Klosa, who's also here with us, and Dr. Shanta Datta, who is also on this live session. I think, thank you, Dr. Datta, for being there. And also our other faculty and staff who contributed. And a special thanks to Emily Miller and to Dr. Shalini Singh, who also did a lot to contribute. We have a big team behind the NHSRC who were instrumental in setting up this course. So a big thank you to them. So a quick word about the Maternal and Child Health India program. We envision a world in which every mother and child experience optimal health and well-being for families and communities to benefit and for future generations. And our mission is to strengthen public health capacity, accelerate research, and reduce gaps in knowledge translation and implementation. And we're so grateful to all of you, participants and learners and faculty, for being part of this mission and having this common goal of improving maternal and child health. So welcome to all of you again. And now it is my deep pleasure to introduce Dr. Alain Labrique, a dear friend and colleague and philosopher who will be taking today's live talk session. So Dr. Labrique is professor and associate chair of research in the Department of International Health at the Johns Hopkins Bloomberg School of Public Health, and is the founding director of the Johns Hopkins Global mHealth initiative. This is an initiative that is highly cited worldwide and one that we're all very proud of. Dr. Labrique is passionate about research in maternal, neonatal, and infant health, and was recognized as one of the top mHealth innovators. He's chair of the World Health Organization Digital Health Guidelines Development Group. And as you all know, India has taken a big leap forward and has developed the country's own digital health guidelines. And we expect to see improvements in health equity. So today, Dr. Labrique will discuss current thinking on digital health opportunities. And the title of his session is The Digital Opportunity for Pandemic Control, Experiences from COVID-19. Thank you very much, Dr. Labrique, for taking this live talk session, and over to you.
Thank you so much, Dr. Shet and Miller and Closer. It's such a pleasure to be here this morning and with such a distinguished audience. Your words are very kind, and I hope I'll be able to shed some light on some of the experiences that we have had leveraging technologies for the control of this pandemic, but also some of the opportunities we have going forward to strengthen our resilience to future health system shocks. So without further delay, let me just also do a quick introduction that about 15 years ago, we started this initiative here at Johns Hopkins, the Global mHealth Initiative, looking at the application of digital and mobile technologies to strengthen health systems and help to address some of the pain points and bottlenecks that we experience in the conduct of our global health implementation work around the globe. And so we have been supporting groups like WHO, UNICEF, ministries of health around the world in developing innovations and implementing and evaluating those innovations in health system strengthening through technology. So the reason we talk about digital health and technology when we talk about global health is because of a fact that's certainly not lost on any of you here in the room today. I'm sure in your pockets or around you somewhere on your table, you have a piece of technology that is more advanced than the entire computer systems that launched the Apollo missions to the moon. And I'm talking about the mobile phone that you surely have somewhere in your reach or vicinity. And this has been I think in no uncertain terms, a revolution in global infrastructure, communication, and just the realities of how societies function. In 2013, the International Telecommunications Union released statistics that demonstrated that we almost had as many mobile phone subscriptions as we do human beings on the planet. So this was in 2013. And the most recent data shows that this is very much in excess of 8.6 billion mobile phone subscriptions, far exceeding the number of human beings on the planet. So it's within this context, this new reality of a connected world where we can reach people at the last mile, no matter how far away they are from an urban center, no matter what socioeconomic stratum they may be a part of. This idea of having access to communication technology is really revolutionary, and one that over the last 10 years with WHO and UNICEF and other multilateral agencies, we have been reflecting on what are the ways in which we can harness this technology, this new landscape of connectivity to strengthen the way we deliver healthcare and preventive health to families around the globe. Whether we're talking about routine immunization programs or maternal and child health care, there are strategies that have been tested and tried in this environment. In 2019, the WHO actually released the first ever digital health guidelines for the global health community based on extensive synthesis of evidence to review the strategies that work and the strategies that are cost effective to achieve health system goals. Now, very early in this pandemic, one of the key ways in which we were involved was in helping governments and groups that were mounting responses to the COVID pandemic think through how this technology could be leveraged to help reduce the impact of COVID-19. So very early in this process, we published a paper that looked at the various strategies that could be repurposed from a non-pandemic time and looked at the landscape of how technologies were being used by different countries, including India, on trying to fill some of the gaps that had been created due to shelter at home restrictions or mobility restrictions that were being implemented as part of pandemic control measures. And so you can see here a short list of the early use cases of technology, ranging from telemedicine or teleconsultations, which many countries around the globe began to harness quickly, all the way through to dissemination of videos, training health workers in how to use protective personal equipment, the development of helplines for COVID-19 for people to call to get information about this, this emerging pandemic, and mental health support, especially during unusual circumstances, social conditions like isolation and quarantine. There were also a number of efforts around the globe to try to leverage these technologies for contact tracing and case reporting, which I'll share a little more about in a moment. So we actually also mounted an entire course to start training students about ways in which to leverage technologies. And sorry, I think someone's mic is unmuted. So where we were looking at how to address some of the pain points and challenges of the pandemic using digital technology. So you can see here we added a few others, including diagnostic hardware, which also has been a source of innovation during this pandemic. I think, however, one of the key lessons that I'd like you to take away from these comments today is that digital, as it has since the beginning of this space of digital health and mHealth, digital gives us the opportunity to rethink how we deliver care, not just healthcare, but also wellness at the population levels. How can we, without increasing the inequities that we already have in our health system, how can we strengthen the way we deliver care, leveraging these technologies that are available to most of the people in populations around the globe to make the patient experience more patient-centered as opposed to physician-centered? How can we make these services convenient and affordable? How can we use this technology to address barriers of access? So where cost or distance might be a major issue preventing people from seeking care, could the phone serve as a way to bridge those problems? Of course, always keeping a strong eye on the challenges of quality. Are we maintaining the highest level of quality as we provide these services? And so there are different models, and this excellent paper that came out in Lancet a few months ago addresses different models where digital technologies can be used in the out-of-hospital setting, for example, to sort and triage patients to make sure the most critical or the most in need patients for that personal contact are the ones coming in, minimizing physical checkpoints, developing hub and spoke models to distribute limited expertise across a wider range of providers, especially when you're dealing with an emerging disease like COVID-19, where information sharing and knowledge is so critical. For frontline settings, there were a number of other models, stream phishing, which is really saying that can we augment the capacity of frontline providers by providing an extra set of hands in the digital environment if those providers need continuity of, if the patients need continuity of care beyond that clinical encounter. You can see there are other sort of models here looking at hybrid models, providing synchronous or asynchronous telehealth, mixing services, some patients receiving in-person care, others receiving digital care, depending on what works best for that patient. But then also, as you move to the outpatient or inpatient monitoring paradigm, thinking about patient-led monitoring of their symptoms, and we'll go into an example of this in just a moment, as well as follow-up by the clinical care team to ensure that patients are recovering or are not having long-term complications as a result of their infections. And so there's many different ways in which digital tools can be used, depending on the appropriateness of the patient population, as well as the appropriateness of the provider population. So today I'm going to touch on 4 domains: communication, prevention, mitigation, and epidemiologic insight, as really key areas where I think there's a lot of promise for digital technologies to be used. Let's start with communication. And telemedicine, I think, has been the one of the most critical areas that has received a great boost during this pandemic. And usually when we used to think of telemedicine in the past, we would think of very sophisticated computerized environments where we're looking at dedicated portals and sophisticated proprietary technology. And in many countries during the pandemic, these restrictions were actually eased to allow the use of other channels such as WhatsApp or Messenger or video calling in order to allow providers to continue to engage with their patients. And I think this was really transformative, not only for the delivery of care, but also for the patients to experience what it could be like if they were able to just pick up their phone and engage with their clinician at their own convenience when they needed help the most. And so I think this was a really important breakthrough in many countries where regulatory environments were fairly restrictive for the use of telemedicine. But over the past 2 years, we've really seen how this is much more feasible. And actually, when you think about telemedicine itself, it's not a new idea. Going way back to the early 1900s, we see here, I just found these 2 magazine covers from the early 1920s, where the idea of telemedicine was already being floated with these, with the advent of radio and television, imagining clinicians performing diagnostic tests or operating even on patients from a long distance. In the United States, one of the things that was done was the Health and Human Services, the agency responsible for regulating health information systems, was actually issued what's called an enforcement discretion. So they allowed people to leverage non-secure or informal channels to conduct telemedicine encounters, which really opened up the availability of telemedicine as a channel for patient support. As a result, one of the things that we saw, and this is just data from early pandemic, it's actually doubled from this point. We saw telemedicine adoption go from 8% to about 25%. And now this has gone up to about 50% in terms of encounters. And this is just in the US alone. In India, there are numerous solutions, both in the private sector and in the public sector, allowing interactions between providers and patients. Moving on now to information, misinformation, and disinformation. One of the things that many of us have experienced during the pandemic was the use of chatbots for symptom checking and for follow-up. The CDC, the Center for Disease Control here in the US, actually launched a framework bot that was then used by many agencies across the country, including Johns Hopkins, to allow patients to come to a website or to a Facebook Messenger channel and many others, including WhatsApp, to check whether their symptoms warranted a referral or an immediate seeking of care, or whether they could wait until they had more complications so as not to overburden an already struggling health system. But I think I want to spend a little time, because this is a problem that really India has struggled with, as well as many countries around the world, but it's the spread of mis and disinformation. And well before the pandemic, we were quite aware that there were bots and trolls and other malign agents who were spreading misinformation about vaccines, about healthcare through social media. And this was a major public health problem. And this is a paper by Bronatowski and colleagues from the School of Computer Science here at Johns Hopkins, going back to 2018, showing that these malicious actors were actively trying to sow discord in the public conversation. So early on in the pandemic, Dr. Tedros, the head of WHO, pronounced that we were not just dealing with an epidemic, but also we were dealing with an infodemic. And so we had to create solutions to help us address this persistent problem of mis and disinformation. And so just to say a few words, misinformation is information that evolves incorrectly as new knowledge is generated. But disinformation is the intentional spreading of incorrect information to create some sort of social anxiety or discord. And so both of these were challenges in what Dr. Tedros called the infodemic. And so people, including ourselves, use social media to generate trustworthy content as an effort to battle misinformation that was spreading rapidly about the source of COVID-19, the treatments for COVID-19, et cetera. And our students actually got together. We have a body of students who represent more than 70 or 80 countries, and they created video content using simple animations that could be dubbed into various languages in order to create trustworthy content about the risks and mitigation of COVID-19. Countries around the globe have used this to spread these types of messages through various social media channels, including WhatsApp, Twitter, and Instagram. Over the last 2 years, we've been developing informational chatbots. So these are technologies that are getting smarter and smarter every day to create the sense of a conversation with a patient. So you come onto your WhatsApp channel or your Messenger channel, and you can have a conversation using natural language with these artificial intelligence agents who have been programmed in advance with sets of knowledge, and then allowing them to respond to the questions that people have about COVID-19 through this natural interface. And what's exciting about this technology is that it is a learning technology. It can identify questions to which it does not have the answer, and then revert back to humans who are in the background to say, I received this question, I don't know how to respond, please help me. And so as time goes by, these chatbots become smarter and smarter. WHO launched chatbots that were translated into many, many languages, and you might have seen this in India through the national COVID response technologies. Here on the left, you see this is inside of the WhatsApp channel, where it's not as smart as the chatbot I was just talking about, but it allows you to push numbers and get predetermined messages to the most commonly asked questions about COVID-19. In terms of training, many groups have developed training courses like this one, but not online, but it's on downloadable apps that you can go to WHO or UNICEF or the International Telecommunications Union and download generic content that can be translated into a number of languages, covering everything from hand hygiene to PPE to managing and reporting pandemic or epidemic cases in your communities. Moving on to symptom screening and mitigation, we just talked about these chatbots that allowed you to screen for necessary triage symptoms. But what we did is also think about how can we use these technologies to augment a dearth of human resources. So where it was impossible for human operators to sit there and respond to call after call after call that was coming into the public health centers here in Baltimore and across the country, one of the things we did was create a hybrid system, allowing chatbots to intake the initial questions. And then when they felt that the person was in need of referral or that they had critical symptoms, the chatbot would escalate the caller to a human respondent who could then provide isolation instructions, who could assess and identify a hospital for that person to go to, or to immediate emergency room care if they needed it. It also allowed us to automatically follow up with cases of COVID-19 to make sure that A, they were maintaining their isolation or quarantine, and B, making sure that they were recovering and not getting more serious, requiring an advanced referral. So during the pandemic, there were, this is an earlier slide, but well over 200 technologies that were developed around the globe to use mobile telephony across these various domains of surveillance, prevention, treatment, and diagnostic. I've provided a link here that you can go to, tinyurl.com, COVID technology, where you can take a look at the technologies that were developed near or proximate to your geographic locations. And so there's a lot that we can learn from each other as opposed to reinventing the proverbial wheel that we often do in this space. We also undertook an evaluation of digital platforms that are used for COVID-19 management. And you can see here, this is another link where we looked at the range of open source available platforms that were being used by the global digital community of varying complexity with different functionalities. And we did a thorough assessment, and this report can be found at this link as well. We tested each of these solutions to look at things like user friendliness, to look at the functional capacities of each of these applications, and to identify whether there were some dependencies that these technologies had in order to be usable in that local environment. Now, you also might have heard, or you might have even experienced, the use of technologies for contact tracing. And in a nutshell, this idea was to see whether we could use mobile phones to speed up the process of contact tracing, to reduce the capacity of infectious diseases to spread in a population. And there were multiple solutions deployed around the globe where the phone in your pocket was quietly sending out a signal, allowing it to identify other phones near which it had been over the course of the day. And so there were, of course, ethical and legal challenges and the need for individuals to adopt this technology for it to work, because without someone turning on their phone and agreeing to broadcast their location and their phone's identity to other phones, this type of solution would not be very successful, as we saw in the pandemic. In India, technologies like Arogya Setu was used to alert users if they had come in proximity with an infected person. Singapore deployed Trace Together. And you can see here the list from the internet of contact tracing applications that used Wi-Fi or Bluetooth around the globe to help strengthen the response to COVID-19. Now, in the US, you can imagine this kind of technology, although it had the potential for great success because of the widespread availability of mobile phones. It was actually not very successful because there was the lack of a governance and privacy framework to help ensure that these technologies could be used smartly. But also there was a lot of mistrust, where about 50% of the American citizens surveyed in this particular Statista survey said that they would not use a contact tracing app because they didn't trust the curation of their data. Lastly, going on to epidemiologic insight, this is a domain that we've used quite actively. We've used this type of technology to evaluate large-scale vaccine advocacy campaigns to try and increase uptake of vaccinations. We've used this technology to measure whether non-pharmacologic interventions like shelter in place or reducing mobility actually were translating into application or adherence. And what this technology is monitoring the location of mobile phones in a privacy preserving way. So without knowing who you are or exactly where you are, telecom companies have the ability to share the location of mobile phones as a wide group. So you can know sort of within a 100-meter or a 500-meter uncertainty where a mobile phone is and whether that phone is moving from one neighborhood to another neighborhood. And those data can be de-identified in a way that allows us to look at movement and clustering of human beings and other critical things to measure a pandemic. So we looked at things like whether travel has decreased, whether clustering has decreased, whether travel resumed after pharmacologic intervention was lifted, et cetera. And these technologies are available in many places around the world. We looked at India as a potential place to leverage mobile phone location as a source of data, but there is a strong urban-rural chasm in the data quality that didn't allow us to use it actively. But it's often not known by most users that this data is available to the networks. As you can see here, this is just a small segment of a data point from a particular set of users. And you can look at everything from the crowdedness of phones together to see sort of whether we're having people densely packed in an environment, or how long people are spending in a particular place in order to assess whether they have the risk of that type of long exposure using mobile phones. So one of the things you can see here, and the animation on the right should be showing you, we actually use this to measure the decline in the number of trips that people were taking since the onset of the pandemic in the US. Google made this data widely available, and it's still available for public analysis. So if any of you are interested in analyzing mobility, please, if you can just mute yourself if you're on the call. And so here's some of the public data from Brazil. You can see massive changes. Sorry, Anita, or...
Sorry, I'm trying.
Thank you. No, it's hard to hear the audio. And so the public data that again confirmed this massive change in mobility after the initiation of some of these legal frameworks for reducing movement during the pandemic. Now, there are other technologies that are emerging, such as connected devices. And although I have to say, I'm not fully convinced that this is applicable to global context or even high income settings, because it requires the adoption of a particular make and model and brand of technology. But the group called Kinsa, who manufactures a Bluetooth connected thermometer, used this to try and map hotspots, where there were a large number of individuals using their particular technology reporting febrile illness as a potential proxy for a COVID hotspot. Now, I would strongly encourage everyone to go to this website and read about the ways in which we measure the applicability or quality of a digital technology that is used for COVID-19 response. And you can see here the 12 different domains that we've identified as critical metrics of performance and success for a digital tool. And this work was led by Dr. Smisha Agarwal, who is the Director for Research of the Digital Health Center here. There are other valuable resources that I would point you to: the WHO Digital Clearinghouse, which is sort of a central repository of technology and digital solutions for health system strengthening at large, but they have created a specific subsection for COVID-19, as you see here, where you can look at WHO reviewed technologies for COVID-19 management. There's also the WHO Digital Health Atlas that if you are working in this space of technology, I strongly encourage you to go here and register your technology, because it helps us to share innovation across the globe and also to prevent the reinvention of wheels. So if somebody else has developed a really excellent solution, chances are that you'll be able to leverage it and not have to spend as much money or time or effort to develop that solution from scratch, because this community, if anything, is extremely collaborative. Now, I want to say a few words about how do we move from a field of shiny objects to sustainable development. Because what happens during an emergency is you have hundreds and hundreds of shiny objects that are developed. And by this, I mean technologies that are cobbled together rapidly. They look really nice from the outside, but the content or the quality of the technology or the innovation is often lacking. And that means it will not be sustainable, it will not be scalable, and it will not deliver on the promises that we expect of it. And so part of this is advanced planning and careful deliberation and preparatory activities for a health emergency. But it also means investing in the foundations. And so as Dr. Shet pointed out at the beginning of this session, India, a few years ago, launched the National Digital Health Blueprint. And this is something that many countries around the world have done to move away from the field of shiny objects towards thinking about sustainability and scalability. And the National Digital Health Blueprint of India, of Kenya, of Bangladesh, of Chile, these establish the framework for a national architecture for interoperability standards. And what that means is standards that will allow different technologies to speak to each other, to share information, to allow patients to be handed off from the community level to the tertiary care level. And I think these also set standards for quality, for performance, and most importantly, for the preservation of confidentiality and privacy. And so with these kinds of foundational pieces in place, we can move towards an ecosystem of sustainable innovation as opposed to one-off short-term innovations that will only last for a few months or years. So I just wanted to outline in closing 5 points that I think are really worth thinking about for those of you who are either in positions of authority to drive change and investment, or for those of you who are on the ground helping to test and develop innovations that will help us strengthen our health systems for future shocks. So one is to advocate for investments in the infrastructure. And it's not a typographic error. I did not mean to say infrastructure. The infrastructure is really talking about the communications, the information standards that are in place, the laws and governance mechanisms that exist at a national level or at a regional level to help developers of these solutions understand what their technology needs to be able to do in order to function in this environment. Well before pandemics occur, we need to invest in primary healthcare and community-based solutions. In many parts of the world, including a lot of the work that we do in rural Bangladesh, we had been developing for years community-based technology surveillance systems that allowed us to transition smoothly when the pandemic began to remote interaction with clients, being able to continue to provide them antenatal care, referrals, advice, wellness checkups, etc., using the mobile phone networks. I think we need to look and learn and understand what technologies people are already using in the communities where we work. If WhatsApp is the major channel through which people communicate, don't introduce another app or another network or another channel for health communication. Ask yourself, how can we leverage what people are already using to strengthen healthcare and health delivery? I think, as I just said earlier, planning in advance and practicing for emergencies is absolutely critical. This was one thing that, as an infectious disease epidemiologist for 25 years, we've been talking about a looming pandemic that was on the horizon. And yet people were not taking this seriously enough. And we saw the result of that, which I think hopefully will not disappear from our collective memories very quickly. And so we'll be able to leverage the resources necessary to create those advanced plans and to practice. But if there's one important message that you remember from these remarks, it is the importance of developing governance and trust frameworks. And what does this mean? The countries where there was a strong legal infrastructure that people could trust in the curation and management and transactional events around their data, there was a much higher uptake of digital solutions for COVID-19 than in places where that trust did not exist, where there was no legal framework around data privacy and data security. We're beginning to see now some of the countries where, Singapore being a good example, where the government had ensured, and I would say rather assured the population that in no way whatsoever would their data, their location data, their proximity data be used for anything other than COVID-19 management. We're now seeing that this was not the case and that their technologies, their location and movement was being actually used for police case solving and for criminal investigations. And so that has really led to a strong pushback where you had a few months ago a really high level of support for this technology. It's moved far, far away from that once it's revealed that that trust was violated. So I think that's a few of the messages that I'd like to share today. And there's hopefully some questions that I'll be able to answer in this short time. But feel free to reach out to me. I'm on email, LinkedIn, Twitter, and many other channels. So thank you again, Dr. Shet and colleagues for this invitation this morning, and I'm happy to answer a few questions.
That's wonderful. Thank you so much, Dr. Labrique. It was really exciting to hear about these different opportunities. and also to think about the potential that it has. Seems like the potential is so large, and we've probably just merely tapped the surface. So we're now open for questions and comments from everyone. Do you have anything to add, Emily?
I think the one thing that really struck with me was the establishment of trust frameworks, and that example from Singapore was really disappointing, because I feel like, that kind of happens again and again, right? With institutions kind of defying trust. That's happened, with vaccines, that's happened with so many times. And so I just kind of wonder, like, how can we be more thoughtful as not just, as a public health community, but just kind of like multi-sectoral, and with all of the different institutions and collaborators that are working in this space, how can we do a better job of preserving that trust and having levels of accountability to preserve that trust? Because it just feels like it keeps happening. And I just didn't know if you had any thoughts on that.
Yeah, but I will say, I mean, from a positive standpoint, I highlighted an example where this didn't work, but Taiwan, as a counterpoint, took a very radical approach to building trust and accountability by simply turning it over to the sort of techno public. So they used a hacker approach to say, the public build a trust framework that's transparent, that can be authenticated. And so they had, hundreds of computer programmers, of health information system analysts joined together and put together a strong system that was transparent, that was accountable, where security was in the hands of the end user. And really they thought a lot about this democratization of that trust framework to be able to use, to be able to ensure that these technologies could not be used maliciously or for non-health purposes. And I think we can go back to the example of the polio campaign in Pakistan and Afghanistan, right? As when it was used for political purposes or for anti-terrorism purposes, it has now had years and years of repercussions downstream, where this essential public health vaccine program now is just no longer trusted by people across the country because of that failure and that violation of that relationship. So, I will say, I mean, the US has very little to say on this, because the US does not have a unified national health information, privacy, and security standard. There are as many standards, as many sort of legal frameworks as there are states and counties in the country. And so the US has a long way to go before this has been achieved. But India, through this National Digital Health Blueprint, is already taking steps towards that level of national confidentiality and security. I see, Shalani, you have a question. Do you want to unmute and ask?
Thank you, Dr. Labrique. I'm sorry, I cannot switch on my video because I'm in middle of a transit. But
No
before I ask my question, I just had a thought. I see a question in the chat, which is very interesting, and it's drawing very much from Emily's question, is how do you create trust when the pandemic is over and people will forget about it and stop using the digital applications that were launched during the pandemic? So a lot of it was created solely for pandemic purposes, but then how do you integrate and make them continue them in mainstream digital ecosystem and institutionalize some of these platforms? I think that is very much was what I was also leaning towards. So I'm glad that Mo asked this question.
Yeah, so I think it's a good question, and there's two important pillars here. One is value. And I think you have to create and convince the end user of the value of the technology. And so, you know, we talk a lot about this this approach that we call design thinking, that comes from the technology innovation space that really centers around the end user, understanding and empathizing with what is the pain point that the end users, and it could be a clinician, it could be a member of a community, it could be you know, a policymaker, but really understanding what are the points of value for that individual is the first step to building a solution that has longevity. And that value may change over time. And so you have to keep asking that question and keep ensuring that you're delivering that value to the user. And so that's one way of doing it. There's also forced value, where, you know, some countries have imposed legislations or fines when a system is not being used. So in some countries, you know, you have to download the application. And if, you know, I think many cities in China actually use this. Kuwait used this as well, where upon landing at the airport, you had to download the app, show the immigration officer that you had the app working. They had to be able to ping your phone. And so, you know, I would prefer the carrot approach versus the stick approach. But that's certainly one thought. The second point is the countries that had this framework of trust and data security were the ones where the first SARS-CoV pandemic years ago was experienced quite dramatically. And I'm talking about sort of Pacific Rim, you know, New Zealand, Taiwan, Hong Kong. These are countries where they realized back then, a decade ago, that they needed to have some solid social pact, legal pact with their people to say, in the event of an emergency, we need to be able to access certain pieces of information. We need you to provide us certain pieces of information in order for us to be able to keep all of our populations safe. And so it took a decade to build that legal foundation in order to be able to leverage technology this pandemic, right? So I think coming out of the pandemic, where the pain and loss and suffering is fresh in our minds, to mobilize political will to say, look, we've just gone through this experience. Before we forget about it, as humans tend to do very quickly, let us think through and build the foundations for future readiness. And I think that is something that funders are ready to support, and politicians are also ready to get behind. And when those two things converge, it's an opportunity for all of us in global health to move the agenda forward.
Yeah, this is really very encouraging. We are getting better at communication using digital technology, but it's interesting that you mentioned how digital health information technology is still something that needs to be improved, particularly in countries like the US. And I love that you talked about sustainability of digital technology, because without reaching everyone and cutting across the strata of society, I don't know how useful this will be in the long run. But I often wonder why it's so difficult in health. Because if we take other systems like the credit card system or the banking system, it's so universal across the world, and it's just there at your fingertips. So why would health information be so difficult? Privacy is the same in both systems.
I will say it's a great question, Dr. Shet. And I think the term that we like to use is called health exceptionalism. We like to think that we are different and special and unique. And I think what we saw happen during the telemedicine boom of the last 2 years is that I'll use the US example. The healthcare system realized that the boundaries that they had placed around the use of telehealth were not driven by the end user. So they were not, design thinking based boundaries. These were boundaries to reduce the risk of litigation, right? So protection of from lawsuits. They were boundaries created to, I'll venture to say to increase profitability, but they were not systems set up to maximize the patient-centered experience, right? And so you think about the financial industry, you think about like the examples that you just gave, the banking sector. If your bank is not providing you the services that make you happy, the customer will vote with their feet, right? They will walk across the street to the new bank that offers online services, that offers a credit card, that offers all of these things. And so there has to be this competition and this spirit that drives innovation. And I think over the next few years, we will see a lot of this demand from populations around the globe saying, no, when it was the pandemic, you did all these things to try and make it more convenient for us. We continue to want and demand this level of patient-centeredness. And it's an inevitable future. Kayur asked the question here, if I can just quickly answer that, about the echo chambers. I think it's a formidable challenge. None of us, really all of us in this room here are public health or medical professionals. We should never underestimate the threat that misinformation and disinformation represents. Some people think that this is a challenge that is reserved to, high income Facebook and Twitter using parts of the globe. I would venture to say that we will start to see trust in public health programs, trust in vaccine programs, trust in health services begin to be eroded by the widespread distribution of disinformation around the globe. There are political scientists who are proposing that some of these misinformation and disinformation efforts are intentional political strategies to fragment populations or to create political discord. The data seems to suggest that this is correct. And so I think, we need to take strong, radical action to make sure that these sort of artificial bots and trolls and other actors that are spreading misinformation get identified and get shut down, because humans are very, very susceptible to information that's delivered in a catchy way that builds on fear, and it can rapidly create massive challenges for all of us in the room who are practitioners.
Thank you, Dr. Labrique. I think, as you said, massive challenge, but it's also heartening to see stuff like debunking coming in, and also companies such as Twitter and Facebook also developing algorithms to, detect misinformation, disinformation, bar these tweets. I think these are all, again, great steps in the right direction, but some of which really need to also be under the purview of, regulations and mandates to kind of make sure that misinformation, disinformation spread
Absolutely.
is
Absolutely.
as
And I think
effectively
some of these corporate responses that you're describing stem from both political and public outcry that not enough was being done to curtail this. However, like with any sort of bad behavior, upstream structural interventions are necessary, but also downstream consumer education is important, right? Initiatives that help educate the consumer, that help to ensure that people are thinking before they share, that they are critically analyzing social media, and they are understanding and believing that they may be manipulated by these sorts of initiatives is something that needs to be communicated to the public. That these echo chambers you speak about, Kayur, exist because people want to believe that there are others who share their worldviews, however dystopian those might be. But I think it's a dual responsibility: an upstream corporate responsibility, upstream regulatory and political responsibility, but also a downstream consumer responsibility.
Great. Thank you, Kayur, for that question and comment. There's another quick comment from Alkananda, who says that the major step for future preparedness is preparing and training of service providers. And I think we all would agree with that.
Yeah.
I think
very, very honestly, I mean, Alakanda, the idea that the beginning of a pandemic is the time to build innovation is very, very wrong, right? The worst possible time to start building new innovations and deploying new systems is when everybody is scurrying around trying to reduce infections and save lives. Nobody has the bandwidth to learn new things and adopt new systems and build infrastructure. So it's sort of why I had as one of my parting 5 bullets, planning and preparedness, right? We have to plan and prepare now for the next pandemic. And so some of you may be familiar with the Trinity Challenge, and there is a number of these kinds of initiatives that are being done. Here's the link. It's a global initiative led by Trinity College to really bring the world's best innovators to the table to develop solutions to future pandemics.
That's great. Thank you again, Dr. Labrique, for taking the time today, sharing your expertise. So this session will be recorded and posted on Course Plus. So there will be opportunity to listen in if you missed this session. So I'll just turn it back to Emily if there's any final remarks. And no?
No, nothing from me. I just wanted to thank you again, Dr. Labrique, thank all the learners for being here, and enjoy your weekend, everyone.
Thank you, Shalini, as well. Thank you so much, Dr. Labrique, and goodbye.
Thank you.
Thank you.